Hi, my name is Reza Hojjati, and I'm going to present 6 difference in functional stress tests or CT angiography in symptomatic patient with suspected coronary artery disease. This is my disclosure. I don't have any disclosure. So we know that ischemic heart disease is the leading cause of death. And we know that based on the report from Center of Disease Control, cardiovascular death is 10 times more than breast cancer death. So it's very important to keep an eye on that when we are talking to our patient about the cardiovascular disease. Ischemic heart disease will be divided to 2 groups of disease, obstructive coronary artery disease and non-obstructive coronary artery disease. The important part that we have in women is that in WISE study shows that 1 in 3 cardiovascular death in women happens because in women that they have non-obstructive coronary artery disease. And it shows us the importance of evaluating patients for non-obstructive coronary artery disease in women. The difference that we will see on presentation between women and men is that women has broader spectrum of presenting symptoms. They have atypical symptoms. They have higher prevalence of non-obstructive coronary artery disease, but as I mentioned to that, they have worse clinical outcome when they have non-obstructive coronary artery disease. This study shows that in a patient that they have any detectable calcium score, means any type of coronary artery disease, and doesn't mean that it's obstructive coronary artery disease, in any level of calcium score, the mortality and cardiovascular death in women is higher than men. So again, this shows that for women, we have to make sure that we screen them not only for obstructive coronary artery disease, but also for non-obstructive coronary artery disease. The goal of non-invasive imaging is not just find the obstructive coronary artery disease. So based on what we discussed, the plan is to find the best outcome. At the treatment to get the best outcome, we need to do risk assessment, we need to do prevention, guide us through the medical management, and guide us when we need to do the revascularization for this patient. Cardiovascular imaging will be divided in different sections. Exercise treadmill is the easy and the first step, a stress echo, a stress perfusion imaging that will be a SPECT or PET, MRI stress test, and coronary CT angiogram or the non-invasive imaging that we can look at coronary artery disease. And as we know in ischemic pathway, each of these tests will look at one step of that. For example, for MRI or PET, they can look at microvascular disease, but also in PET will look at perfusion, the same as SPECT. MRI can look at perfusion, or it depends on the protocol that we use, can look at wall motion. In 2014, the guideline for evaluation of ischemic heart disease in women recommended that patient that has low risk, we do low to intermediate risk, we do exercise stress test, and in patient in intermediate risk, for patients that are not able to exercise, we do a stress imaging or CTA. And we are going to go through that, and probably this recommendation needs some adjustment. I'm going to go over each of these method of evaluating and the benefit and the problems that we have with those. For example, for exercise treadmill stress test, we know that it will give us a lot of information about the cardiovascular fitness, about the blood pressure response, about the chronotropic response, about the heart rate recovery, and it doesn't have any radiation, so all positive finding. However, if patient is not able to exercise, if they have baseline abnormal EKG and ST depression, those are problems for doing exercise stress tests. We know that in women especially, it has very low positive predictive value. And also, it will not give us any information about non-obstructive coronary artery disease. And as I discussed, looking at non-obstructive coronary artery disease is something important when we are evaluating women for ischemic heart disease. A stress echocardiography is another way to look at the coronaries and looking at ischemic heart disease. It can be done with exercise or with pharmacologic stress test. It will give us information about the wall motion and systolic function. It will give us information about the diastolic function, pulmonary artery pressure, and also other information that we can get on echo, like valvular issue, and it doesn't have any radiation. However, the problem is when we have limited acoustic window, that will be a problem, especially in women that they had breast surgery. We know that on those patients, sometimes we have limited echo we use on looking at the heart. If the patient has baseline wall motion abnormality due to previous cardiac event, that will make interpretation a little difficult. And again, it will not give us that much information about non-obstructive coronary artery disease. The next way of evaluation will be a stress myocardial perfusion that could be a SPECT or PET. Again, it can be done with exercise or with pharmacologic stress test. It will look at perfusion. It will give us information about ejection fraction. And we know that PET will give us very nice information about myocardial flow reserve that is important on women, especially when we are looking for macrovascular disease. The problem that we have with those type of stress tests will be radiation. We know that the SPECT could give up to 11 millisievert radiation. PET depends on the tracer that we use, 2 to 3 millisievert. We know that in a SPECT we can get breast attenuation. We know that there is a problem with availability of PET. And again, for non-obstructive coronary artery disease, we don't get any information from those tests. Stress magnetic resonance imaging is the next way to look at the ischemic heart disease. Magnetic MRI will be pharmacologic stress test. Most of the centers are doing pharmacologic. It doesn't have a radiation, that's good. There are two protocols that we use. Either will be wall motion when we use dobutamine and doesn't need contrast, or when we use perfusion that we use adenosine or regadenoson, that we know on that one we need to use contrast. It will give us ejection fraction information. It will give us some tissue evaluation like late gadolinium enhancement. So those are very good evaluation of the heart. The problem that we have is if patient has contraindication to MRI, that is a limitation. If patient has any contraindication to using a contrast, the other problem is availability. We know that it's certain centers that you are doing a stress MRI. And again, it does not give us any information about non-obstructive coronary artery disease. In this slide, we will see negative predictive value and positive predictive value for obstructive disease in different testing. And as we see, positive predictive value for exercise stress test in women is very low. The next way to look at the coronaries is by using of coronary CT angiogram. The coronary CT angiogram will give us information about non-obstructive disease, and that's very important. As we mentioned, in women, 1 in 3 that cardiovascular that is with non-obstructive. So that's the only method that will give us information about non-obstructive disease. We can look at the plaque in the coronaries. Calcification or remodeling are some of the factors that we can evaluate. And also cardiac CT angiogram will give us information about the anatomy of the heart and some information about the function. The problem that we have, it has radiation. The dose with dose reduction method could be 2 to 5 millisievert, and in some centers they can do it with lower radiation. We know that we have to use iodine, and if there is a contraindication, chronic kidney disease or allergies will be a problem. In patients that are tachycardic, atrial fibrillation, frequent ectopy, we may not get good quality study. In patients that we have high BMI, again, that's a limiting factor, and we know that a stent, coronary stent, is not very good to be evaluated by cardiac CT angiogram. So these are the limitations that we have with cardiac CT. Accuracy trial showed that 99% negative predictive value for CTA. So CTA has a very, very good negative predictive value for evaluation of coronaries. Another thing that we can look on CTA is looking at the plaque morphology. So for example, spotty calcification, napkin-like calcification, positive remodeling, or low attenuation plaque, those are high-risk features, and those increase the possibility of event in the future. We know that this is a very active part of the research, and there are a lot of research going on to finding out what is the high-risk features, but these are some of those that we know. Another thing that we could add to the CT scan is fractional flow reserve CT that will give us some information about function. So with adding FFR CT is not just anatomic evaluation, but it could be a functional evaluation. And we know that FFR CT added a good amount of information to the CT scan. We know that there are some research that they are suggesting that FFR CT may be giving us different information in men and women, and maybe we have to look and more research on difference that there are between men and women on FFR CT. Pacific trial is a trial that look at compare different way of non-invasive to cardiac angiogram with FFR. The comparison was between SPECT, between CT by itself, between PET and CT with FFR CT. And on that study, it shows that the most accurate way to look at the coronaries probably is CT with FFR CT, and we can get the most information from that study. In a Scotthart Trial, it showed that patients that go under evaluation by CTA versus patient that goes under a standard of care, they have lower amount of mortality. The explanation of this is a little more complicated. That study shows that this patient has fourfold increase in taking aspirin and statin, but I think the difference in mortality was not only because these patients taking more statin and aspirin, but also was because of the behavioral change. A lot of these patients, when they know that they have coronary disease, they will do some behavioral change, like healthy diet, or like stop smoking, more exercise. So I think it's not just taking aspirin and statin that shows this benefit, but the whole behavioral change and more healthy lifestyle was what makes this difference between the standard of care and CT. And probably you will see in your practice also, when you tell a patient that the stress test is normal, patient thinks that her heart or his heart is normal and he doesn't or she doesn't need any other testing and she doesn't need to be careful. However, when you tell them that you have coronary disease, you have a 25% plaque, but you don't need any procedure, but need to take medication, patient is more careful, and patient following the instruction, taking their medication. We know that the Ischemia Trial was published last year. It was comparison of invasive treatment versus medical treatment. And we know that one of the important steps on that trial was that 73% of patients had cardiac CTA to exclude left main disease. And we know that there was no difference in primary endpoint on that study. Again, this is very important for CTA. We know that that study was not designed to look if the CTA will decrease mortality or it will make any changes, but we know that on that study, the only way that non-invasively you can look at the left main disease is with evaluating of CTA. And again, this is, I think, very important factor in coronary CTA. With coronary CTA, not only we can define the level and area of obstruction, but we can look at the left main disease. And that's, we know that left main disease or three-vessel disease are the part that in SPECT we have some limitation and we sometimes see normal stresses on those patients. This is a comparison of the regular stress test and CTA, what we can see. In the bottom, you will see a SPECT that is normal, but a normal SPECT does not mean normal coronaries. Any of the top three pictures could be the result of this stress test. Patient could have completely normal coronaries in the left, right, in the top left. In the middle, patient has mild coronary artery disease, or in the right, patient has non-obstructive coronary artery disease, but patient has high risk plaque. And from the medical management, these three will be different. Probably on the patient that has normal coronaries, you will not start statin very early. Patient if has LDL of 90, you will tell them time to do some lifestyle modification and see what they are doing. However, on the patient on the right, probably you will start the statin earlier and you want to do a more aggressive medical treatment for that patient. However, you will not get this information from a normal stress test in a SPECT or PET or a stress echo or a stress MRI. So this is what makes the cardiac CTA different from other modality of the stress test. This is the difference between radiation that you can see in different modalities. Again, as I mentioned, in SPECT around 11 millisievert, in PET between 2 to 3, in a coronary angiography around 7, in cardiac CCTA with dose reduction, something between 2 to 5, and now in some centers even less than 2 millisievert, depends on the protocol that they are using. In 2019, ESC Guideline now in management of patients with stable coronary artery disease, they give class 1B to cardiac CTA for evaluation of this patient when they are presenting for further evaluation. Again, this is based on the above studies that I show you and a lot of cardiac study that has been done. And in 2020, ESC Guideline for management of patients that presenting with acute coronary syndrome, they recommended CCTA as class 1A for evaluation of these patients. So we see that CTA now is getting more and more attention because of the all possible good information that we can get from the CTA. This is a recently published paper in JACC that recommended for patients with a stable angina, you can start with medical management, and if there is no response, coronary CTA can be done, and based on that, you can guide your management. So for evaluation of patients that presenting with coronary artery disease and ischemic heart symptoms, this is a way that we could consider for evaluation of this patient. If patient has low to intermediate risk, especially in younger women, and if they are able to exercise, probably an exercise stress test will give us a lot of information. It doesn't have radiation, and we can get good information from that. However, if patient is not able to exercise, the exercise stress test is abnormal, or patient is intermediate to high risk, especially with abnormal resting EKG, probably cardiac CTA with FFRCT will be the first and best choice to do a stress test or to do evaluation. Other choices will be a stress echo, a stress MRI. PET and SPECT also will give us a lot of information. We have to consider that if you're evaluating for macrovascular disease, probably PET and MRI will be at the top choice. But first, in this patient, we have to evaluate for obstructive disease, and CTA will be the first choice. If patient has previous intervention, as I mentioned, in a stent, CT is not a good option. So for those patients, probably CMR and PET will be the best option. SPECT and stress echo are the other options. We have to consider on patients that they have CABG, if we are not looking at the original coronaries and we are going to look at just bypass grafts, then probably CTA is a good option because CTA will give us a lot of information about bypass graft, and it's very easy to evaluate bypass graft with CTA. So the conclusion is that women that are presenting with abnormal stress test and non-obstructive coronary artery disease should no longer define as having false positive test. They are at high risk for cardiovascular mortality. The goal of non-invasive imaging is to identify the extent and severity of coronary vascular dysfunction, non-obstructive coronary artery disease, or obstructive coronary artery disease, and guide us for clinical management. Thank you.